Those of us here at Colorado State University are proud to share with you this session of Endoscopy Talks. When you're looking for inspiring veterinary CE experiences, think CSU Vet CE. Nestled up against the Rocky Mountains in our new State of the Future facility, we invite you to experience what we call CE Elevated. We'd love to see you in one of our future on-site, online, or blended courses. Check us out at www.csuvetse.com. Now, please enjoy Endoscopy Talks.
Hello, everybody, and welcome to Endoscopy Talks. I'm Christopher Chamness with Carl Stortz, and I'd like to thank you for joining us on behalf of Colorado State University's Translational Medicine Institute, also known as the TMI. Today, we have the pleasure of hearing from Professor Stephen Divers, who needs very little introduction in the world of exotic animal medicine and surgery. He graduated from the Royal Veterinary College in London in 1994 and is currently a clinical professor at the University of Georgia College of Veterinary Medicine. He is extremely well published in endoscopy and surgery of exotic animals. He has lectured at more than 80 conferences domestically and abroad, and has provided practical training and workshops in more than a dozen countries. So without further delay, it's my pleasure to introduce a good friend and colleague, Stephen Divers.
Thank you, Dr. Chamness. Let me see if I can share my screen. Hopefully you can now see my PowerPoint. Someone will shout at me, I'm sure, if it's not visible. I'm going to be hopefully keeping you alert and awake for the next 45 minutes or so on the topic of exotic animal endoscopy. And I know we've already had one topic covered, bird endoscopy by the great Lorenzo Crosta. But I think this is an important lecture because I think this gives you the foundation as to why and how to get started before you then start thinking about learning the procedures themselves. So endoscopy has been an integral part of my career. I was in private practice from 94 to 2001. I think that's important because a lot of the things I'm going to talk about have direct relevance from private practice, actually come really from private practice. So I'm not talking as someone in the ivory tower of academia, although I've been in academia since 2001. But for me, endoscopy at the University of Georgia, and specifically in exotic animals, has facilitated an international Fulbright specialist, a PhD and a master's, over 70 publications, around $300,000 in extramural funding. We've had visitations from 6 countries. We've consulted and taught in 9 countries. And it's created a lot of continuing education, both at the local, regional, national, and international level. So it's been a very important part of my career. And I'm hopefully going to impart some of that enthusiasm onto you this evening. So really, and don't get worried, because whenever someone starts a lecture at 400 BC, there's always a concern this is going to go on for a while. But I just want to draw your attention to the fact that Hippocrates, who was a pretty clever guy, I mean, this is the father of medicine, and around 400 BC, he reported the use of a candle illuminated rectal speculum. That was the first definition or the first example of an endoscopic procedure that I could find. However, given the fact he's an intelligent guy, think about what he's doing here. He's using a naked flame in a rectal speculum, presumably with people that have some form of large intestinal problem or issue. So I think he was a brave person from that regard. But since 400 BC, there's been considerable development. 65, we saw Professor Hopkins, a Brit, develop the rod lens telescope, which is still the core design. It's been improved, but it is still the core design that's used for the rigid telescopes today. And then since the early 2000s, we've seen the development of high definition, 4K, 3D camera systems, and integrated OR. So there's been a huge development over the millennia. Oh, no, what's going on? Okay, sorry, I had a bit of a glitch there. So let me come back here for a second. So when we think about what is endoscopy, it's really the minimally invasive techniques to see inside, to biopsy internal structures, and increasingly to perform minimally invasive medical and surgical procedures. And we're all taught that the physical examination is the cornerstone of medicine, but really we're looking at the external physical examination. One of the things that endoscopy can do really specifically in a lot of the exotic patients that we deal with, is it enables us to perform an internal physical examination and really complete that picture and really be able to get a complete overall evaluation of the animal. And it's not unusual that we're using endoscopy inside these exotic species for an evaluation and examination, and we may not expect to find certain things that we end up finding. And if you look, you will find. I think one of the problems that plagues exotic animal medicine is the fact that I still see a lot of clinicians relying on the diagnosis of liver disease or the diagnosis of kidney disease or respiratory disease. So we're diagnosing to an organ level. And really what we need to do is get away from that and get to a histologic and etiologic diagnosis. And the only way you can do this, you can't do this with imaging, you can't do this with blood work. You really need, biopsies. You need to get a piece of material that you can submit to get that definitive diagnosis. And there are many ways that we can get that material, but we need to be able to demonstrate a host pathologic response. And there's a couple of ways we can do that. Paired rising antibody titers. Well, there's very few serologic tests available, and those that are available take several weeks. And most of my exotic pets, particularly the mammals and the birds, are either cured or dead within 2 weeks. So that's going to be more of a retrospective use. And so we tend to rely on histopathology. Now we can use cytology, and cytology is used very frequently in humans and domestic animals. But when you're dealing with exotics, there's a lot less comfort dealing with cytological evaluations, I think, and you lose that tissue architecture. So histopath that maintains that tissue architecture is preferred. And then in addition to demonstrating that host pathological response, we need to demonstrate and identify the causative agent. Often that's through microbiology, but it can also be through toxicology and parasitology. And so we've really got two options. We can kill the animal and perform a necropsy. And if you're dealing with a large population, if you've got, an aviary of 300 cockatiels and there's a disease process, then an elective euthanasia of a couple of sick animals is probably the cheapest, most expedient way to make a diagnosis. But if you're dealing with animals of individual high value, whether that's because they're high value because it's an individual pet, or because it's an endangered species or an exhibit animal in a zoo or an aquarium, then we need an antemortem biopsy. And there are various ways we can do that. We can do a surgical approach to the coelom, and we can take our biopsies via a coeliotomy or a laparotomy. However, I'm hopefully going to show you that I think endoscopic approaches are far less traumatic and far more useful. And I think that the benefits to the animal are considerable. So I just want to I just pulled a couple of cases just to give you some examples of some of the things that we contend with in exotic animal practice on a regular basis. And I've just thrown together a few cases that I'd like to just to demonstrate. So this is a rabbit. Rabbit presents with capricious appetite. It's not eating. It's forage. We have a complete skull survey series here. And the boarded radiologists were unable to see anything specifically untoward on the radiographs. And so this is now an endoscopic exam inside this rabbit's mouth. This is not me doing this. This is a first-year resident, but I think you can see quite clearly that we've got an obvious abnormality here associated with this tooth, and the tooth is actually fractured. And I remember phoning up the radiologist saying, can you see that left upper premolar 2 is fractured? And they went back to the radiographs. No, they couldn't see that. But my first-year resident was able to see it, and you can not only identify, but using the endoscope in the oral cavity gives you an incredible ability to use it as a surgical aid for performing dental procedures. We don't think about that so much in humans and in dogs and cats because you've got a wide gape. But when you're dealing with these small mammals with this small oral connoisseur, then the endoscope can be, really instrumental for disease diagnosis and also treatment. Let's take an avian example. This is this was an Amazon parrot that presents with respiratory issues, and hopefully you might be able to see here that we do have a increased opacification in this region, which is commonly associated with the caudal thoracic and abdominal air sacs. So we are concerned that there's some lower respiratory issues. On the ventrodorsal view, it looks pretty clear. But this is the endoscopic video. And you can't even see visceral structures. You should be able to see kidneys and intestines and the gonad and the lung, but you can't see anything because it's covered in fungus. In fact, the magnification of the scope is so good that you can actually probably make a speciation based on the structures of the candida that you can see there. And so the endoscope gives us the opportunity to take biopsies. Now, I know there may be some in the audience that will argue that you can make this diagnosis without resorting to endoscopy, and you can diagnose it with galactomannan levels, aspergillus titers, but you won't get a microbiologic MIC value. And once you start taking samples, you'll be surprised at some of the resistance patterns that you may be seeing. So again, we still do those clinico-pathologic evaluations, but the biopsy gives us a diagnosis not 4 days later when the blood results come back. They give us the answer, at the time when we're doing the procedure. So again, that's another example in the bird. This is a nice case involving a ball python. This animal was kept, it was a 10-year-old kid's pet ball python, kept it in his bedroom. And this animal had chronic respiratory signs. It had 3 lung washes, lung lavage for cytology and microbiology. Mixed gram-negative were identified. The animal was put on 3 or 4 different types of antimicrobial therapy. Didn't improve. You can see the radiograph there showing the multifocal opacifications in the cranial lung field. Whereas when we did an endoscopic exam, you can see we've got granulomatous changes, and these granulomas indicated by the black arrows were biopsied, and we actually got the diagnosis of mycobacteriosis within about 3 or 4 days. The cultures took 9 months. What's concerning in this case is that they actually cultured Mycobacterium haemophilum, which is known to cause disease in immunocompetent children. And so here you've got a case of an open mycobacteriosis case, undiagnosed for months, because no one actually looked down and took a biopsy and performed a basic bronchoscopy and endoscopic exam of the lungs. And here you can see the acid fast stain. So again, histologic diagnosis was quick, microbiologic diagnosis took about 9 months. And just another bird case here. This bird presents because the referring veterinarian thought, based upon this radiograph, that the animal had proventricular dilatation disease. Reasonable working diagnosis based upon that radiographic picture. But when you did a contrast study, you can see that we don't really have a big flaccid fluid-filled proventriculus. There's a lot of filling defects in that proventriculus. And on ultrasonographic exam, it wasn't a big fluid-filled structure. There was tissue and filling defects within that lumen. And so again, here's an endoscopic video going down through, just gone from the crop, and we're going into the intracoelomic esophagus, into the proventriculus. And as we enter the proventriculus, you see normal proventriculus, actually just here at the bottom. You'll see normal proventriculus at about 6 o'clock. Here we go, the bottom edge here, and all this granulomatous tissue. And initially I was thinking, well, I've seen adenocarcinomas, and I'm thinking this was probably some sort of neoplastic lesion. So took biopsies using our 5 French down this 2.7 system, and biopsies come back, wasn't an adenocarcinoma, those are nematodes. And this was a case of a spiroid infection, only being diagnosed post-mortem in a few zoo birds previously. No one's ever was able to perform an ante-mortem diagnosis, let alone successfully treat the case. They all died. In this case, endoscopy facilitated the diagnosis, facilitated the treatment, fenbendazole. Bird made a incredible, well, I guess expected recovery, but the owner thought it was incredible, and the animal went on to do very well. Here's the same bird about 4 or 5 weeks later after fenbendazole treatment. You can see the proventriculus now is largely normal. This is using a flexible scope. You can see the ventriculus, the green ventriculus in the background there. You couldn't even see into the ventriculus previously. So again, endoscopy gives you that opportunity, as it's minimally invasive, to go in, make a diagnosis, and go back in and confirm that things have improved. And then apart from diagnosis, we also have the option of doing certain sort of surgical procedures now. And these are just sort of 2 examples of things that I do fairly regularly. The first one on the right here, this is a laparoscopic ovariectomy. being performed in a rabbit. This is probably a 1.5, 2 kilo rabbit. This is using 3mm instrumentation. And on the right, this is a granuloma actually right over the heart base. So you can see the heart is actually sort of fluctuating underneath, and this granuloma is over the heart base. Previously, people have not been able to get to these areas to surgically resect or to remove masses. Individuals have tried, they've had to remove the keel, and birds have invariably died before the procedure was completed. Here, you're actually looking at a second-year resident performing an endoscopic resection of that granuloma. In this case, this was a Saker falcon. And this particular bird came all the way from California, from the West Coast to the East Coast to have surgery. And this is something that I think can be done, you know, in many practices, exotic animal practice up and down the United States and elsewhere, with just some basic training and some basic equipment. And here you can see on the right, you're seeing the endoscopic ovariectomy in the rabbit. These animals do so much better with this endoscopic approach than the traditional laparotomy. The post-operative discomfort and pain seems a lot less. These animals seem to bounce back so much more quickly. And I think you also have the benefit that the less manipulation you do of the other visceral structures, the less chance of developing adhesions in the future. So there's just a couple of examples of endosurgical, and I think there's a huge evolution that can occur and progress that can be made when it comes to the endoscopic surgeries in these animals. So I think the real value to me of endoscopy is that it improves my diagnostic abilities. So I think it improves your clinical services and your revenue streams, your client satisfaction, your level of medicine. And for me, my professional quality of life just went up considerably. All right, so have I convinced the people out there that maybe there is something to this, not to shut down the computer at 8:20, but may actually stick it out for the next 40 minutes. So are there any questions based upon what's happened so far?
Well, Steve, we don't have a lot of questions yet, but we sure have a lot of participants and they're not leaving yet. So I think they're glued to the screen.
Okay.
Let me ask you just one question, or there are two questions here. I'm sure you're going to get to this, but somebody asked, what is the main scope, the first scope that I should use for doing these kinds of procedures? I assume you're getting to that, or are you not?
I'm definitely going to get to that.
Okay.
And I'm not going to say now because that's the next bit.
Okay. And this other question is, how far can you go ab-orally with a rigid endoscope in avian species? Of course, it depends on the size, but I'm asking depending on anatomy.
So I can get, yeah, it does depend on the size, but typically for most of the parrots and even some of the raptors up to about maybe a kilo, kilo and a half, I can get into the ventriculus up to about 400 to 500 grams. I can get into the ventriculus from an oral approach. If I do an ingluviotomy and go through the crop, then up to a couple of kilos, I can get into the ventriculus. If I'm going up the other end, and I'm a great believer, if there's an orifice, use it. So if I go into the cloaca, typically I can evaluate the proctodeum, the uridium, and the coprodeum. I am very nervous, and I don't recommend trying to get into the rectum because I think there's a danger with a rigid scope of causing a tear. With flexible, maybe, but with rigid, you're restricted to the cloaca, which is okay because the vast majority of problems we see are associated with the cloaca. All right, I'm going to keep going, okay?
Okay.
All right, so how about adding endoscopy to our practice? And I basically think there's a 6-step plan. And I'm going to go through these steps over the next sort of 30 to 40 minutes. And we're going to go through the case audit, the appropriate equipment to meet your needs, initial training. How do we charge for it? What's our fee structure? How do we market these skills? And how do we maintain them and continue to provide evolving services to our clientele? So I think one thing that's a good idea to start with is to review your caseload from the past 3 to 6 months and determine what you're actually seeing, not what you think or hope you're seeing. And I'm guilty of this. If people ask me what I see, I'm like, oh, I probably see like 30% reptiles because I love reptiles. I don't. I probably see about 18% reptiles. So it's important to go through and actually see what are you actually seeing? What are the cases you're actually dealing with? And that helps to direct your equipment priorities. It also reveals current practice cultures and recommendations that you may need to change in order to integrate endoscopy. If your whole approach to aspergillus diagnosis in birds is protein electrophoresis, galactomannan levels, and serology, well, you're going to have to shift that because you won't have to wait 4 days, 5 days to get those results. You can actually do an endoscopic and actually get a microbiologic culture and diagnosis. And you can get that diagnosis, at least grossly, the same day or the next day. So, and also if you're doing rabbit rodent dentals, if you're not using an endoscope, once you start using an endoscope, you're going to get pictures and videos. You're going to use those for client feedback. Or if you start doing small mammal ovariectomies, if you've been doing ovariohysterectomies, well, you need to start re-educating your clients about the fact you can do endoscopic ovariectomies as long as it's before about 9 months of age. So some of those cultures will need to change. It also indicates the possible demographics for focus marketing. If you're doing a huge number of rabbit dentals and rabbit spays, then you want to make sure that you offer to give a little presentation to the local rabbit society group. If you're doing a lot of avian work, then a presentation to the local cage and aviary group would be the way to go. So it gives you some ideas for focus marketing. These are just some figures that basically I pulled out of my cloaca, but this gives you some sort of broad sort of idea. These are, like I say, it depends on your location, but again, just think about, how many cases of rabbit dental disease do you see? Do you see any otitis in rabbits or in ferrets? Do you see any birds with respiratory signs or regurgitation? Do you see any birds with cloacal prolapse? And just start to look at, if we did endoscopy, how would that factor into the fee structure? What sort of money might we be thinking about? And the reason I want to show this is that this is just 4 cases. And yet you can see it easily covers the monthly lease payments if you bought a brand new system. And so most practices, I think, could do a lot more than this. And a lot of people are probably in mixed small animal with exotic practice. So I'm not even looking at the dogs and cats here. But I think it's a very practical, a very financially viable option. Having an in-practice CT machine, I think, may be more of a struggle. Having an in-practice endoscopic service is a no-brainer. It really is. And that's where my 7 years in private practice comes in, because I've seen it work in private practice. I've seen other private practitioners make it work, and it succeeds relatively easily. So equipment selection, you can't buy everything. But the systems are modular and customizable, so you can always add more later. So you want to use that case audit to focus on what your actual demonstrated needs are for the cases you're currently seeing. Now, there are some essential common elements: the camera, the monitor, the light source, and cables. That's going to be the same for all procedures. But then the variable items will depend upon your caseload: the telescopes, the sheaths, the instrumentation. And so that's the bit that can be added on and varied depending on how things move and how things go. Now, list prices are often discounted at conferences and wet labs. So if you're thinking that was when we could go to conferences and wet labs, hopefully that will start back up again soon in 2021. But you can often get discounts at conferences. So if you're thinking about making a purchase, then it might be good to try and think about fishing out those prices at a conference. And then this was a survey I did, and it's a few years old now. It was done in 2014. The items that I've highlighted here are the ones that were most common. And this was a survey. I sent this survey to about 30 to 40 exotic animal endoscopists, people who are known to do exotic animal endoscopy, because I wanted to find out, what do they find most useful? And so you can see that the majority of people were using xenon light sources. At the time, 2014, standard definition cameras. I'm sure that if we surveyed people now, the differentiation or between the standard and the high definition cameras will probably be reversed. I'm sure more people are moving on to high definition. You'll notice also that the mobile endoscopy tower with the endoscopy equipment on a mobile cart was very common. And coming back to that question about what would be my first scope, if I was on a desert island and I could have one scope, it would be that 2.7 millimeter telescope with the sheath and instruments. There's also now a 2.7 integrated telescope with an integrated sheath. But that 2.7, I think, really is the workhorse in exotic animal and indeed small animal rigid endoscopy practice as well. So these are these were numbers that was provided to me by my local rep late last year. So these numbers might be a little bit out of date, but I'm just showing you the numbers to give you the ballpark. You're looking at around about, $30,000 for a complete brand new system if you go with Telepac HD monitor light source 2.7 scopes. If you're looking to do small mammal laparoscopy, then really it's the endoflator, which is the big ticket item. And with that, you're looking at probably in the region close to another 20,000. I will say that there is often secondhand equipment from the human side that the Karl Storz reps will often tag for some of their veterinary clients. So my plug here is to make contact with your local Karl Storz rep. Mine is actually on fast dial on my cell phone because if I have questions or need to have a chat, he's available to me. And that's one of the big advantages, I think, of Karl Storz is they have a dedicated veterinary side to support us in the veterinary profession. But you can often get secondhand endoflators, which will obviously cut that price significantly. But anyway, just to give you some ballpark ideas on numbers. So the exotic animal system, high definition telepac 2.7 system, between 30 and 40, depending if you're going standard diff or high definition. Laparoscopy set between 10 and 20,000, depending on the endoflator. If you're just starting, just go with a 2.7 system. Laparoscopy is an additional skill set. It's more difficult. So get used to the single entry procedures with that 2.7. Once you get comfortable with that, then you can add and move forward with laparoscopy. So you certainly don't need to get both at the same time. But they do a lot of lease purchase options. And like I say, if you get the system with laparoscopy, the complete shebang, then, you're looking at around about $1,000 a month. And, you've only got to do 3 or 4 procedures to cover that. And we should be able to do that easily. Like I say, secondhand equipment is frequently available through your local reps. I would be very cautious. In fact, I have heard I've seen disasters of people trying to mix and match different manufacturers. And it might seem like a good idea, but the frustration level I see build up, and all it does is kind of, detract from the pleasure and enjoyment you should have by having a well oiled system that works well for doing these procedures. So I wouldn't mix and match. They do adapters and things like that, but really I think it's a path to frustration. Okay, step 3, initial training. Well, often when we have conferences, we have introductory workshops and wet labs. Usually these are 3 or 4 hours, and you can undertake these exotic animal endoscopy sort of introductory workshops at the ARAV, the reptile vets, the avian vets, the small mammal vets, the zoo vets, North American Vet Conference, and other major small animal vet conferences will often provide these training courses. Specialty center training courses are also available. You've got the center in Colorado that does a huge number of small animal and courses. University of Georgia, where I am, currently we're the only place doing the 2-day exotic animal course. It was 3-day, but we've now gone to online for the lecture component. And so we've now been able to expand the practical, but limit it to 2 days. So that's been an advantage. And that course is very popular. The idea is we get people that are complete novices when they come in on Friday afternoon, and when they leave on Sunday evening, they're prepared to go into practice the next day and scope a macaw and take a renal biopsy if they need to. It's all about being very practical. And so this is the information on the course that we've got, which is done. This is an online course, the lecture component, and you can see the website below. And then there's also a 2-day hands-on component, which is limited to only 16 people. But the online is available and was very popular this year. I think being online, we can now reach further afield. So we have a lot of international interest in that course. Okay, let's get on to some of the nitty-gritty of charges and fees. There was actually considerable variation in equipment charges in my 2014 survey. Endoscopy or operating room fees were about $47. Endoscopy towers, people were charging about $152. Exotic endoscopy packs were about $111. This was in a lot of academic institutions. They would, nickel and dime, and they divide everything up. I think in many vets in private practice probably collate a lot of these fees together into a single sort of endoscopic equipment or endoscopy use fee, and then they'll have a separate professional fee. There was also greater consistency in applying separate charges for things like anesthesia, histopathology, and microbiology. So that was much more consistent. Now, when it comes to actually looking at the professional fees, this was a bit of an eye-opener for me. About a third of the respondents used a tiered fee structure, like a level 1 to 6. It's simple, it's flexible, it allows pricing mobility. So if I talk to Mrs. Jones and say, I'm going to scope your tortoise, I want to go in and scope your tortoise, I think we need to get a liver biopsy, it should be a level 3. If it's really difficult and problematic, it might be a level 4, and it's very simple and quick, it could be a level 2. Clients understand that graduation in fees, whereas if you quote them a fee for tortoise celioscopic liver biopsy and it takes you 3 times as long, you're kind of stuck with regards to you've already quoted a specific fee. So I think that gives you a lot of flexibility. A third actually of vets had a very specific procedure descriptions and fees. So they would have a set charge for reptile celioscopy, avian tracheoscopy, small mammal otoscopy, much more complex, a lot more fee codes that you have to put into your computerized medical record system and financial accounting system. However, it does allow you to do better auditing. You could search for the number of avian tracheoscopies you've done or the number of rabbit laparoscopic spays that you've done. So it gives you a little bit more business management information. And then the scary part, there's a third of the respondents said they actually had no predetermined fee structure. They just made it up as they went along on a case-by-case basis, which I think obviously provides the greatest flexibility, but I think there's a danger that you're going to see undercharging or overcharging, and that can cause some issues. So at the University of Georgia, we do a tiered fee structure. These were our current professional fees. So this is just the endoscopy professional fee going from level 1 to 6. And I've given you some examples there. So level 1 would be like an oral exam in a rabbit, or an ear exam in a ferret, or a cloacal exam in a bird. And then level 2 will be a basic celioscopy with biopsy. Level 3 will be multi-site or complex celioscopy with biopsies. And then levels 4 and 5 are basic and more complex endosurgery. And then I've also got a level 6 here because the computer system wouldn't let me put in a level 0. So we had to add this one. And this was for sex identification. And so this is what, when we're doing endoscopic sex identification in birds or reptiles, this is the cost per animal, but there's a $500 setup fee. So if someone brings you 12 birds to endoscopically sex, then, you know, or 10 birds, 680 plus the 500. So it's a way of being able to do those numbers. And then here's just some examples of the mean values that people reported back in 2014, just to give you some idea of the charges that were being levied just for the professional fee. So not the equipment fee, not the anesthesia fee, not the biopsy, histopath or microbiology fee, just the professional fee. Small mammals, again, showing the variation. And a lot of people were doing a lot of otoscopy, stomatoscopy, rhinoscopy, and the ovariectomy has come online now, has become more and more popular. And then on the reptile side, these fees are actually adjusted to 2018, but again, shows you the level of professional fees that were being levied for some of the procedures that we would do on a fairly regular basis. So hopefully that gives you some idea as to the sort of practice management component and the fee structure. Again, if there's any questions on this segment, or indeed if there's any questions over actually what we've covered so far, I will be happy to answer them. Dr. Chamness, are you there? Are you fielding them for me?
I am, in fact, Steve, and we've got several questions here. Let me begin. I'd like to know how frequently you perform gastrointestinal endoscopy in exotic animals.
How frequently I perform gastrointestinal endoscopy? We do it quite frequently. I'm trying to think now because I spend 3 weeks on clinics, 3 weeks off clinics. And so I remember the last case we did, I think was a couple of weeks ago. We had a goose with a hook foreign body that we had to take to endoscopy to remove that hook. But basically, you'll do a lot more once you start to change your culture. And I'll give you an example. Let me throw an example. Ferrets. How many people see ferrets? How many people see ferrets with gastric disease, gastritis? How many people will make the assumption that it's Helicobacter and put them onto antimicrobial therapy. Whereas if you've got a chronic case, if that was a dog or a cat or a human, gastroscopy would be a standard part of the investigation. And yet in exotic animals, when I talk about performing gastroscopy in ferrets, people look at me sometimes like I've got two heads. And so I think we need to change the culture. Same for birds. If I see a bird, how many times do you see birds that are regurgitating or vomiting? And, again, gastroscopy is like the standard investigation. The indications, people ask me, what are the indications in a reptile or a bird or a small? I'm like, ignore the fact it's a bird or a reptile. What are the indications for performing gastroscopy in Ettinger for dogs and cats? And those same indications should be applied to exotics. And so I think it's a case of we exotic practitioners need to kind of elevate ourselves to the same standards of dogs and cats and humans and utilize that equipment. So I think you'll find that you can do that quite frequently. But certainly I think I do it mainly, reptiles, birds, and small mammals. Small mammals, not so much gastroscopy, not in the rabbits. Stomach's never empty, but certainly in the ferrets, I would certainly do that as a fairly standard investigation for chronic vomiting or chronic gastric issues. Anything else?
Yeah, speaking of dogs and cats, I've had basic training in small animal laparoscopic and flexible GI. Am I ready, or do I need special courses in addition?
Well, it depends. I mean, if you've been doing a lot in Chihuahuas, I think you're set to go. I mean, if everything's been 35-kilo Labradors, then I mean, basically, it's amazing to me that once you have the technique, it is not there is a miniaturization, but you've got magnification. I think that if you've got training in the dogs and cats and laparoscopic procedures, I think you're ready to go to do a laparoscopic ovariectomy course in rabbits. That's the Sunday that we do basically at UGA is we do mammals, and we're using slightly different equipment, slightly different techniques potentially, but I think you would be good to go. I probably would do one of those training courses, or at least do maybe a couple of your own rabbits or cadaver rabbits maybe before you let loose on a client-owned animal. But I think the skill sets are very similar. Yes.
Okay, what is the benefit of a rigid scope versus a flexible scope?
For what? For upper GI work? Are we talking about
What does
mainly?
it say? I think just in general, when do you choose which one?
So if I'm doing anything within the body cavity, it's going to be a rigid scope. The only time I'll use a flexible scope going inside the body cavity is in a big snake. So if I go in like a 16-foot python, I want to go in and look in its lung's about sort of, 5-6 feet long. So I'm going to use a flexible scope so I can go up and down. But most of the time, celioscopy, laparoscopy, it's going to be a rigid scope. I will use a rigid scope if I can to go into the upper GI of birds and reptiles, because I feel like I've got more control and I can manipulate things a little bit easier because I maybe that's just me because I came through rigid endoscopy. Maybe if you were a flexible person, you'd have more comfort with the flexible. Once the animal gets over a certain size, that 18 centimeters from the 2.7 is not going to get down there. And so that's when you need to go to the flexible. So for me, if I've got a macaw, if I don't want to make an incision to go through its crop to get into its stomach, I'm going to use a flexible scope so I can go per os and not have to make a surgical approach. So for me, with a macaw, because I've got a flexible scope, I would use it. When I was in small animal practice or exotic animal practice, private practice, if I didn't have a flexible scope, I'd make a surgical incision, go into the crop and then into the stomach. So I can still get there with the rigid, but once the animal gets bigger, the flexible's preferred. So it's more of a size issue than a procedural issue.
Mm-hmm. What type of flexible scope do you routinely use? Size and brand?
Okay, so a couple of at one point I want to make. All the equipment that I use is Karl Storz. I am not paid by Karl Storz. The other point I'd like to make is all the equipment that I use in my hospital is not donated. We pay for it, and we pay for it at client fees. And I think that's an important point to make. I think it's an important question that you should be asking, because I think a lot of times we can get somewhat biased because we're getting equipment that may be donated or discounted. That said, my approach to flexible endoscopy, I do like, and I'm horrible with numbers on the flexibles. I believe I think it's a 5.9 someone can correct me, I think it's around about 5.9 or 6 millimeter flexible scope that I use for most of my upper GI work in exotic species, below a couple of kilos. It's a Karl Storz video scope. If I need something very small, then we have a ureteral scope, which I think is 2.5 millimeters. I use that. And if it's a big animal, like for instance, that goose I was talking about, we did the hook. I think we were using an 8.9 millimeter Karl Storz flexible scope. So, you know, when you're dealing with animals that range from a 35-gram parakeet to an 8-kilo swan, no one piece of equipment is going to get you in every place in all situations. But I do think that the 2.7 is probably the most versatile. And if I was going to get a flexible scope for exotics, I'd probably go with that 5.9 would probably be my choice. I don't know if it's a 5.9 gastroscope or if it's a 5.9 bronchoscope, but
Correct. It's a 5.9 gastroscope.
it is. Okay. Yeah, that's the one. That's the one I tend to use. I can get that down ferrets. I can get it, down larger, down rabbits and down ferrets. I can get it down birds. I can get that down, an 800-gram cockatoo. I can get that 5.9 down into its stomach relatively easily. So that would be the one I would use.
Okay, I'm going to ask you one more in the interest of time. For many of our patients, even if the procedure isn't extremely risky, the anesthesia can be. Can you speak to the difference in time under anesthesia for some procedures via laparotomy versus endoscopy, like, for example, ovariectomies in rabbits, for the experienced endoscopist versus a beginner?
That's a really good question. I can tell you the first time I did a laparoscopic ovariectomy in a rabbit, it took me like an hour and a half. However, that rabbit still recovered so much better than one that I could do in 20 to 30 minutes. I guess I would turn that around. And I would say that if we are that concerned about our anesthesia, we probably need to focus on that first. Because in academia, even if I'm doing a routine rabbit spay, that animal's going to be under anesthesia for at least 2 hours because it has to go into prep, it has to get induced, it has to get instrumented up the wazoo, then it has to go into the OR and gets clipped. It's a 2-hour procedure. So for me, it's not a huge amount of difference, but I do think that, and that's actually one of the reasons for the endoscopy course that we teach at UGA, we actually give, I think it's 3 hours specifically on anesthesia for endoscopy, because we got to get to the point where we're not rushing, we're not worried about the anesthesia, because we have to have confidence in anesthesia so that we can focus on the endoscopic procedure. Now, if it's a critical case, then I think the important thing, and this is something we have to bear in mind, often clients delay or they don't perceive it's a problem. By the time they bring that animal to you, you're on that sort of terminal decline. The animal's had this problem going on for days, weeks, or months, and so you've got a high risk situation. That's not a problem of the procedure or anesthesia. That's a problem of the fact the animal's presented at a very late part of the disease process. So there's that factor as well. But for me, I want to make my anesthesia safe and effective such that I don't worry about the anesthesia. I worry about the trauma and the manipulation of the animal, and I still feel that it's preferred, the laparoscopic approach. Laparoscopic approaches, me with experience, I can probably do a laparoscopic ovariectomy in a rabbit in about 30 minutes. I could probably still do it slightly quicker with a standard approach, but I'm more interested in how the animal's going to recover. Well, when you first start, yes, it could take you an hour and a half. In fact, the first time you do it, you might not be able to do it, and you'll have to convert to a traditional open procedure. You've got to give yourself that get out of jail free card when you're first starting. All right, we got to get going. Otherwise, I'm going to keep people here too late. All right, so what about step 5, practice marketing? Well, if you're using a camera, you can get image and video capture. You can use it on your websites and your ads and brochures. Everyone's got, Facebook, Twitter, Instagram accounts now. These images get out there, and it's very impressive when clients can see what's going on. And you need to show them the pictures and the video, because they're not going to see that single suture closure of that bird celioscopy. They're not going to see those single sutures, subcuticular sutures that you use to close that rabbit ovariectomy. So you need to be able to show these images. And then we also use them in endoscopy reports. And if you are seeing a referral basis in your exotic practice, great way to educate the vets who are referring to you as to what you can now do endoscopically. The other thing that we do at the University of Georgia, and I think a lot of other practices do this, is to have an open day so that the public can sort of access the behind the scenes areas. And one of the most popular areas that we have is our endoscopy stations. You know, you can see the kid on the left here, he's going in there, he's after these gummy bears, and they have to go and pick up these gummy bears, transfer them or remove them. And then even the parents, I mean, look at all these kids on the right-hand side over here. I mean, they're desperate to have a go, but mum's not going to let them have a go. She's kind of one holding the camera. So it's a kind of a tag team going on over there. So this is, I think, great. Obviously, don't let them use your pristine equipment. If you've got anything that's, old, bent, chipped, or some old plastic disposable equipment, then, use that. But it works well. I mean, you can laminate images and videos. This is what I used to do. This is old school. Now we actually have images and videos on the exam room computers, so we can just put them up and show the videos to the clients. But this was a way of being able to show them, stepwise what we're planning on doing. And I think really one of the keys is verbal delivery. And it's largely dependent on your comfort level, which is why this training is so important. If you haven't had the training, you're going to be a bit more skeptical. You're not going to have the confidence, So Mrs. Smith, your African grey appears to have respiratory disease, most likely fungal, but could be bacterial. We could anesthetize for radiography and even perform endoscopy, or we could start treatment today with antibiotics and antifungals. Well, you give that sort of presentation to anybody, why on earth would they want to proceed into the operating room and endoscopy? Compare that to Mrs. Smith. Your African grey appears to have respiratory disease, but there are several possible causes and different treatments. We need to stabilize before briefly anesthetizing for radiographs to direct the best approach for endoscopic biopsy to determine the most appropriate treatment. Precise diagnosis will maximize success. The difference between those two is how confident are you wielding an endoscope? And that's what we try to impart during those 2-day hands-on courses, to get people confident when they go in on Monday morning to say, yes, Mrs. Smith, I'm going to scope your bird and find out what that respiratory issue is. And then I think giving the client the endoscopy report discharge and showing them the video will impress. Now, this is back in 1997, so I'm showing my age here. You can see that my choice of scrubs was slightly skeptical and somewhat dubious. I don't know if you can tell, but there's actually an earring in my left ear. So it goes to tell you how long ago that was. But this is one of those old VCR TVs. You remember, anyone that's over the age of probably 40 may remember these VCRs integrated into the TV. We used to pick up the monitor with the VCR, march it into the exam room, plug it in, get the VCR, winding forward to like 1 hour, 12 minutes and 3 seconds, which is when we did that procedure, and show the client. And it would always impress. How do you maintain these skills? Practice, practice, practice will provide for greater competency, speed, and success. I would recommend that you keep the equipment unsterile to encourage practice. If you get wildlife cadavers, then you'll be happy to use unsterilized equipment. But if it's been sterilized, we as veterinarians have this innate resistance to open up anything to practice if it's been sterilized. So don't keep it sterilized, keep it unsterilized so you can practice with it. You can also make plastic Tupperware trainers. You can get commercial trainers, but you want something a bit smaller. So here's one of my sort of plastic Tupperware trainers. And here you can just see I'm just doing a bit of dissection. And it may seem very arbitrary. And it's like, well, how does that relate to then going in and debriding or removing a granuloma from a heart base of a hawk? Well, there are studies that have actually shown that these trainers do actually impart skills, the perception, 3D perception, and instrument triangulation. Those skills do translate from these trainers into the real world situation. So although it might look crazy, they actually are a good idea. And then one technique that I found was to offer minimally invasive necropsies. So, you get, Mr. Brown's cockatiel unfortunately passes away. And he doesn't want the animal to have a full necropsy because there'll be nothing left but a bunch of feathers. You know what these little birds are like. Once you do a necropsy, there's not a lot left, certainly nothing cosmetic. Well, we would do an endoscopic necropsy. If we had a very fresh, the animal died in the practice during treatment or before we could do treatment, we'd offer an endoscopic necropsy. We would go in this very fresh carcass. We could have a look around, take samples, send them off for histopathology and microbiology, and the client got their whole animal back for home burial or to take home. And so that was actually great practice. It was an additional revenue source where clients would otherwise refuse necropsy evaluations. And here's the good news: it's already dead. You can't make it worse. So there's no risk. So that used to work out very well. When it comes to evolving services, you have to be prepared to evolve your endoscopy services as practice demands dictate. So, for instance, endoscopic ovariectomies in rabbits, pet pigs, bears, and tigers, I started getting requests to do them. And so we developed the skills and we learned the skills and then we started doing them. That was not, I guess, unexpected. What surprised me was the sex identification in juvenile chelonians. I did it as part of a research group, as part of a research project, developed the skills. And then since then, I think we've done over $50,000 of clinical endoscopy work by clients paying for that service. I would never have come up with that otherwise. So I think you've got to be aware and be flexible. Where are the clinical pressures? Where is this endoscopy going to be of benefit? I've been asked to scope freshwater mussels to take samples for ecologists. I've been asked to do endoscopic gonadal biopsies for wildlife ecologists looking at sturgeon reproduction. And clinically, again, requests for doing all sorts of different procedures. So I think you need to have an open mind, and there's lots of growth which is possible. And so add to your system as your caseload dictates. You're seeing more small birds and reptiles, a lot of cockatiels, a lot of geckos. How about getting a 1.9 integrated telescope and 3 French biopsy forceps? Great for the cockatiels and the small reptiles. You're seeing more rabbits and other mammals under 10 kilos interested in laparoscopic surgery sterilization. What about 3mm laparoscopic instrumentation? Not just for your rabbits, but what about all your cats and your small dogs as well? Seeing a lot of dogs or larger mammals, then maybe interested in laparoscopic surgery, upgrade to a 5mm system. So you can manipulate and you can evolve as your caseload dictates. Standard of care. Back in 1994, I went to an endoscopy wet lab taught by Don Harris and Michael Taylor. And Don Harris said, you can't be an avian veterinarian without endoscopy. Avery Bennett, in the same year, in the textbook Avian Medicine, still probably one of the best avian textbooks out there, he said continued development in the endoscopic surgical equipment available in human medicine will undoubtedly improve the surgeon's ability to perform surgery in difficult to reach areas of the avian coelom. How right it was, because a couple of years later, endoscopy, Carl Storz came out with the first pediatric endoscopy catalog, and that's when things opened up for me in exotic animal endoscopy. And just because I'm a bit of a megalomaniac, I'm going to add my own little quote here because I'm allowed to, because it's my presentation. But I think human and domestic animal medical standards of care make it impossible to provide modern veterinary care to exotic patients without endoscopy. You simply cannot claim to be an exotic animal veterinarian without it. And so I think, when you take this, and this is over decades, there is a wave, a pressure to get to grips with endoscopy. These techniques were developed for humans, 70, 80 kilo hulking mammals. And yet we're dealing with animals that weigh 200 grams, 600 grams. They will benefit from these minimally invasive procedures just as much, if not far more. So in summary, again, we went through case audit, select equipment, talking about the need for basic training, the fee structure and marketing, and then how do we maintain these skills and evolve these different services. That's the end of my presentation. It's 4 minutes to 9. I think we got time for a few questions, again, on any topic, preferably related to exotic animal endoscopy, but I'll take a stab at, politics or anything you want.
Okay, for a heart-based granuloma in a falcon, what's your approach surgically?
Endoscopic. I don't think there is an approach surgically. You mean endoscopically?
I assume she means endoscopic.
Yeah. So basically, we made a small coleotomy incision on the lateral side behind the last rib, about 2 centimeters. And then we were able to go in with our telescope and forceps. And that video you saw, I was actually the camera person and I was holding the camera, and it was my resident that was doing the procedure. You'll notice also there's never any audio in my endoscopy videos, and that's because there's a lot of inappropriate talk and chatter that goes on. But so you make about a 2 centimeter incision, get both instruments in. You are limited on your triangulation because they're almost going parallel, but the option was no one's ever been able to do it before, and yet we were able. A second year resident was able to do it and did it well, and the bird survived and did wonderfully well. So that was the technique. Relatively simple, to be honest.
Here's an easy one. How do you sterilize your scope?
I'm going to move I'm going to move this so I can actually look at you, because otherwise I keep looking to the side. We typically use gas sterilization. So I think we're using Sterad, hydrogen peroxide, routinely. That's in the hospital. If I'm doing stuff in the field, or if I'm doing a research project and I'm having to get through more animals, more larger numbers of animals more quickly, I'll use cold sterilization. So I think it's the Sidex OPA is the one that we use with sterile water to rinse. Now, when I first started, autoclaving was not an option. However, I think pretty much all the modern rigid equipment now is autoclavable. And I always get nervous because I think, oh, that's terribly aggressive. But to be fair, a lot of these chemicals, I think, can be more damaging if they're used inappropriately. So I think my rule is always follow the manufacturer's recommendations. So, those manuals that you get, it's amazing to me, my iPhone, incredibly complex piece of equipment, and it came with like a pamphlet. Whereas if you get a Karl Storz lead, it comes with a 47-page manual that covers absolutely every possible eventuality. So, but basically at the back of those manuals for your endoscopes, they have their sterilization recommendations, and I would always follow that. And I'll give you this is a story that I remember. Is we were doing a research project, and I asked Karl Storz, I said, can I use bleach? Can I use 12% bleach to sterilize my biopsy forceps? Because we have to do a number and we don't want cross-contamination, and bleach will denature DNA that won't affect our PCR. And they said, oh, no, we don't think so. And I said, well, I'll try it. And I dissolved 3 biopsy instruments, and Karl Storz said, yeah, see, we told you not to do it. So my rule is always do the manufacturer's recommendations, but typically Sterad, cold sterilization, and autoclaving for some equipment. If you get older secondhand equipment, make sure, because if you autoclave a non-autoclavable scope, it is a very short but spectacular sterilization cycle.
Okay, we've arrived at the hour, but if we can go over just a couple minutes, there's a couple more good questions I'd like to get in. When dealing with respiratory disease in birds, they're often in decline and difficult to stabilize. How do you justify anesthesia versus a broad spectrum treatment?
Good question. So that's it depends if it's upper respiratory or whether it's lower respiratory. So let's say it's an upper respiratory blockage, a syringeal granuloma, tracheal obstruction. I want to place an air sac tube. That's actually a therapeutic process. Well, rather than just throwing in an air sac tube, I'll thread the air sac tube over my scope. So when I go in, to make sure that I'm actually in the correct air sac space to put that air sac tube, I can literally spend 30 seconds having a quick look, because if I see pathology down there, my prognosis is going to decrease, so I can give that information to the client. If it's a lower respiratory tract disease, I find your best chance is when these animals first come in and you stabilize them and you get the diagnostics done. If you wait and delay, they invariably may get worse the next day. The other thing I'll say is that I don't think I've ever lost a bird, even with severe respiratory disease, that's actually on 100% oxygen. The danger is wrestling with a bird that's conscious, breathing 20% oxygen. To me, that's a much greater risk. And I have birds birds that have respiratory disease. We're going to do imaging first, but they all will get radiographs or CT. They're all going to be under sedation, because if they're relaxed and they've got flow by oxygen, you've got a much more stable patient. So I am not worried about that. Now, if the bird does die, when you necropsy it, you have got such pathology that it was probably never going to actually get to the point that it was going to survive anyway. And in those cases, we like to follow up with necropsies to check. But in my experience, looking at these necropsies and looking at these cases, I would encourage you to get in sooner rather than later, stabilize and oxygen.
2 more questions. How often do you use rigid endoscopy to place endotracheal tubes in rabbits for anesthesia, and how much would you normally charge for that?
Okay, so yes, we invariably use a 2.7 or a 1.9 telescope to place our endotracheal tubes in rabbits and guinea pigs and chinchillas. All these small herbivores will use the endoscope. How do we charge for it? We just include that as a part of our anesthesia fee, just like we invariably put catheters into these animals. So our anesthesia fee might be higher because we're using an endoscope to intubate and we're putting a catheter in, etc. But we will routinely use an endoscope. Because we've been doing this a long time, I've got some old telescopes that have been bent or chipped. And so we don't throw those out. We will use those to actually use those for the intubation process. But I routinely use the endoscope, and I think it greatly improves your ability to place those endotracheal tubes. And there was a recent paper that got published in the Vet Record comparing laryngeal mask with intubation, and still having a protected airway has a lot of benefits to it. So yes, I'd use a rigid scope.
Okay, last but not least, are guinea pigs difficult to scope past the palatal ostium? We see some cases where we suspect esophagitis, and I'd like to be able to confirm this.
Oh, easy to get down the esophagus. It's a problem to get through the glottis into the trachea. So actually being able to intubate a guinea pig using an endoscope can be a challenge. Often what we'll end up doing is having, but to get to the esophagus is easy. Just blindly go anywhere towards the back and you're going to end up in the esophagus. Although if that's your goal, you'll probably end up in the trachea. But usually I find getting into the trachea is the more challenging thing. But yes, you could definitely go into the esophagus. Now, if you're doing upper sort of GI esophagoscopy work, just be cautious that you don't want to put fluid down there if you don't have the animal intubated. You would, I tend to use more air to dilate, but no, you could certainly do that. And that 2.7 or the 1.9, that will get pretty much all the way down to the distal esophageal sphincter or even into the cardia of the stomach, although usually the stomach's so full of crap, literally, because they perform cecotrophy. So it is literally full of crap. So you can't see much in the stomach.
Okay. Steve, thank you very much for this information-packed and eye-opening presentation. Once again, I'd like to thank all of you in the audience for joining us. Our next talk will take place in 2 weeks and is entitled Otoendoscopy in the Chronically Discharging Ear, What Are We Missing? This session promises to be unusually interesting as it will be presented by 2 speakers, a DVM and an MD, Dr. Munir Qureshi from California and Dr. Mahmoud Bhutta from the UK, who have worked closely together for several years studying the differences in how we treat chronic ear disease in dogs versus the way human ENT specialists treat similar conditions. That session will take place on February 10th at 8 p.m. New York time. We hope to see you there. And remember, any past talks can be viewed free, including this one, online at endoscopytalks.com. Wishing you all the best of health during these challenging times. Bye-bye.